Hello, I'm here to provide a detailed overview of chronic obstructive pulmonary disease, or COPD, exacerbations. A COPD exacerbation, also known as AECOPD, is a sudden worsening of respiratory symptoms beyond normal day-to-day variation. These episodes are critical because they accelerate lung function decline and significantly increase hospital admissions and mortality risk. What causes these exacerbations? Respiratory infections are responsible for about 70 to 80% of cases. Common viral triggers include rhinovirus, influenza, RSV, and coronavirus. Bacterial infections like Haemophilus influenzae and Streptococcus pneumonia are also frequent culprits. Environmental factors like air pollution, smoke, and extreme weather also play a significant role. Poor medication adherence, such as missing inhalers or incorrect technique, is another major trigger. When an exacerbation occurs, we look for cardinal symptoms like increased dyspnea and changes in sputum. Patients experience worsening shortness of breath and difficulty performing routine daily activities. A change in sputum color to yellow, green, or brown is a clear clinical indicator of infection. Severe symptoms like cyanosis, confusion, or the inability to speak in complete sentences require immediate attention. On physical examination, we may find wheezing, tachypnea, or tachycardia in moderate cases. Severe findings include a respiratory rate over 30 and accessory muscle use. Smoking remains the strongest risk factor, along with a history of previous exacerbations. Comorbidities like heart disease and diabetes also increase the risk and complexity of management. Severity is classified as mild if managed with bronchodilators only, and severe if hospitalization is required. Diagnostic evaluation includes clinical assessment and laboratory tests like arterial blood gas. Imaging like chest X-rays or CT scans helps us rule out pneumonia or pulmonary embolism. Prevention is key. Smoking cessation is the most effective intervention we have to slow lung decline. Vaccination against influenza, pneumonia, and COVID-19 significantly reduces the frequency of episodes. Maintenance therapy with long-acting bronchodilators like tiotropium is essential for stability. For acute treatment, we use short-acting bronchodilators like albuterol as first-line therapy. Systemic corticosteroids like prednisolone lead to faster recovery and shorter hospital stays. Antibiotics are indicated when there is increased sputum purulence or volume. Oxygen therapy must be carefully monitored with a target saturation of 88 to 92%. In the emergency setting, we follow the ABCDE approach: airway, breathing, circulation, disability, and exposure. Non-invasive ventilation is indicated for respiratory acidosis and can prevent the need for intubation. Mechanical ventilation is reserved for life-threatening respiratory failure in intensive care settings. In summary, early recognition and effective prevention are vital to managing COPD exacerbations and improving patient outcomes.